COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities.
In Westminster and the clinical lead for the Community Health Wellbeing Workers in Westminster. Also work at Imperial as a senior clinical fellow, and I'm at the local authority for 1 day a week, and also a mum and love being at Paul's meetings.
Thank you. Hi, everyone. I'm Victoria Tzortziou-Brown. I'm a GP in East London, and I have been a GP in East London for over 20 years. It is wonderfully diverse, but also very, very deprived area. But I love working here, and I have some amazing, very committed colleagues. So I have been in the same practice for all this time. And I have experienced the continuity with my patients, but also the community that we serve. And I have been part of the RCGP as well for since I qualified, really. Paul and I were at the same RCGP faculty. So I joined when Paul, I think, was chair of the faculty at the time. And have remained a very active member since then. And then I joined the Central College, and now I'm the Vice Chair for External Affairs, and I am applying for the chair role, which is a huge responsibility, really. I don't want to even think about it, but it's elections. So what I have said in my statement is I would like to have 3 priorities. And the first one is developing a new vision for general practice. So reviewing what we want for general practice, the future of general practice going forward. And I think it is really important that this is underpinned by continuity of care. There is a lot of evidence on the importance of continuity, relational continuity, not just for patients, but also staff and the system, benefits of it. Evidence-based care and also person-centered care. And I will come a little bit on that in the relationship with how do we work with communities. The second priority is how do we support our workforce? So at the moment, we are in this bizarre situation where patients want to see their GP, and our newly qualified GPs cannot find jobs. So we have unemployment for the very first time in general practice. Huge uncertainty. If people find a job, usually it's part-time, so they cannot really do the number of sessions that they want to do. And this, of course, results in reduced morale, and a lot of people are leaving general practice either to do other things or relocate somewhere else outside the UK, which is such a shame. So I would like us to address this issue. And the third priority is about connecting and working better with members. At the moment, the college advocates for members quite well, but I think we are missing an opportunity from not learning and developing solutions with members, a little bit co-production, more co-design, sharing, learning, sharing knowledge, what works in different areas, and developing together. So I will tell you a little bit about my journey, because I haven't just been a GP. In my area, I was involved in commissioning, clinical commissioning as well. And I think this is quite important when we think about how do we work with communities, and also in view of the health plan that is going to be announced, which is going to be talking about neighborhood working. So when I was involved with commissioning, my first exposure to commissioning was as planned care lead. And as you know, planned care is very much redesigning clinical pathways, with a lot of the time having a very biomedical approach to care. So I worked very well with specialists, secondary care colleagues, to redesign these pathways, make them more efficient, improve communication. All of that was really good, but it was still quite biomedical. And when it really kind of hit me how biomedical it was and the ineffectiveness of it in a lot of cases was when my colleague GPs highlighted that our chronic pain pathway was really not working. So we were referring people with chronic pain to rheumatology. The system was more efficient, the waiting times were less, but actually what was happening is they were coming back just being prescribed medications. And essentially becoming addictive to those medications as well. So the idea came from my colleague GPs, and also we had health trainers at the time, and very good relationship with our health trainers and local psychologists. And we thought we can develop a better way of dealing with chronic pain, and we thought we will focus on back pain. And we developed this chronic pain program, which combined mindfulness and psychological approaches and yoga, which was run in collaboration with our community psychology team and the health trainers. And the population that we served was very, very diverse. We had my practice serves 70% of my patients are from Bangladesh, speak different language, a lot of them. And women couldn't mix with men. So there were a lot of cultural issues that we had to deal with. But still, we managed to develop tailored courses for this population. And we evaluated what we were doing, and actually it resulted in a lot better outcomes in terms of not just pain, but general well-being. And we thought that's great, we will publish it, we will get more funding, we will expand it to the whole of Tower Hamlets. And at that point, a reorganization happened and we lost our health trainers. Then there was an opportunity at the CCG for me to take on integrated care. To become the integrated care lead. And coming from planned care, apart from this experience on chronic pain pathway, I really found it quite hard to grasp what is it that we are trying to achieve with integrated care. And I went really through a journey trying to understand how can we work together, when should we work together, when does this offer a value? Because actually bringing people from different backgrounds together, it can be very expensive. And unless you have a clear purpose, it almost feels like meetings for the sake of meetings, really. So it was a real journey understanding what the different teams and the different other stakeholders, including the local authority, could really offer. But then we managed to develop a vision for integrated care in Tower Hamlets, tried and we got things wrong, and then we amended those things. So, for example, we tried risk stratification based on admission. Again, a very biomedical way of looking into these things. And then we decided to change our approach. And then we ended up having 3 key groups where we were working really together with other stakeholders. And these were the group on children and young people, which focused on how do we improve the health of our young people in Tower Hamlets. And we have very high levels of poverty, tooth decay, and obesity, and lots of issues with our younger population. So we had to work with schools as well. And then we had the Living Well group, which were our healthy adults, but always at risk of becoming ill. And how do we work then with public health in improving prevention and engaging with our communities? And then we had the Promoting Independence group, which included those patients with complex conditions, including social care issues. And we worked very, very closely with our social care colleagues there on improving care plans and all that. And we developed the I statements. We asked our communities what matters to them, rather than us trying to impose outcomes that we thought from a medical perspective were important. So, and of course, again, another reorganization happened, CCG is finished, ICB started. So 10 years later, I'm now the ICB lead for research and innovation. So, yet again, I find myself working with communities, this time very much on the subject of increasing participation and diversity in research through a refreshing program, actually. It's called Research Engagement Network, funded by NHS England. It's unique because I think it's one of the very few programs commissioned by NHS England that is not micromanaged. So we were given a small amount of funding, but the freedom to engage with communities and the VCSE sector in order to increase participation in research. And we were not told how to go about it. We were just given the funding to come together and decide how it would work for our communities. And we managed to engage really well with thousands of people. We produced videos advertising the importance of research. And we have lots of plans of how to engage with social prescribers, etc., going forward. So through all these years, I guess what I learned is that working in a different way requires time and space, requires funding and resources, because if clinicians and others, our teams and VCC said, are very busy and unfunded, they will never really prioritize coming together. You need to protect time and give them the resources to do that in a safe space. And also what I learned is that you need this funding and commitment to be long-term, because I experienced personally the success of coming together and finding solutions, but then the disappointment of external factors getting in the way and plans having to stop and relationships lost. So thinking about all of this and the opportunities that we are going to have with a health plan, which is going to be published in the next few weeks, I would like your thoughts on how can we, what should we be advocating for? From my perspective, thinking about neighborhood teams, I have heard a very muddled purpose for those teams. It's not very clear what the neighborhood providers or teams are going to be there for. So some people think all of this as GP at scale, so delivering general practice services, but just at a bigger footprint. Other people think of it as a vehicle of bringing care out of hospital and into the community, but in a very biomedical way. So, for example, instead of doing diabetes outpatients in the hospital, we will bring the diabetes consultant in the community and we will deliver the clinics there. And other people who are probably more, they have experienced the power of properly integrating with others and working with others, think in a much more ambitious way of how do we work together around populations to serve, to deliver this more holistic care in an integrated way. But I think the purpose is very unclear at the moment to me, and the pace of change is extremely fast, which is quite interesting because I think relationships always need time to build and trust needs time as well. And in terms of outcomes, I think we need to get this right, because I'm again worried that a lot of the outcomes that policymakers sometimes pay attention to are these quick wins, which tend to promote quick access to medical care, something that can be easily measured, and mainly focusing on activity and transactional care rather than meaningful relational interactions and holistic care. So I think we have an opportunity, but it's how do we ensure that we build on it in a way that can be sustainable and can add real value and meaning rather than ticking a box. So
on your suggestion about what the future of general practice might look like, and I obviously I don't want intricate detail, but what sort of approach would you be having? Because number one, obviously, how do we identify what the members think about future general practice? But if we are going to come up with a solution, and this is relevant to the 10-year plan, the 10-year plan I expect will be much more short-term than anything, because politicians have to deliver on things. But also, it may not be as localism-based as we would hope. And I wonder if, and this is what I was saying at yesterday's separate meeting, whether we need to do some work now with primary care, community services, whatever, to develop models that can show the powers that be that localism is safe in our hands. Because at the moment, there's often a negative view of what general practice or community services do, that we're very much not priorities. And I just wonder if you had any thoughts about that. I don't want this is not an exam question or anything, but
yeah.
But it's
Well,
you get ourselves ready for a future at whatever time it is, when there is much more focus on localism and local people, whether that's providers and the public, and that's not the way the health service generally has gone.
No. I do think that, and there is evidence, of course. I talked about continuity. I think relationships are really, really important. And in order to develop these relationships, we need more GPs. There is no way around it. At the moment, we have one full-time equivalent GP per 2,300 patients. It's not you cannot deal with the need out there. And this is at a time where our population is increasing in size, but also complexity too. So I think we do need to start measuring the number of GPs per patients and ensuring that we have more GPs at practice level. We need to strengthen the GP practice as the foundation of the NHS, because a lot of the interactions, the management of patients is happening there. And then we need to provide people with the resources, GP practices with the resources to then engage with external stakeholders that are relevant, including community teams, be it social care, be it secondary care, to develop these other pathways that need to support care going forward.
Victoria, thank you very much. It was very interesting what you said. One thing that caught my attention was that you mentioned the health trainers, and I'd like very much to know a bit more about what role you felt the health trainers played in developing this pain pathway, and what impact it had when you no longer had access to them.
And I feel there's so much wisdom in the community, and that people actually really know what other people need and what they themselves need, and that we're kind of I think Fleur de Meyer called them sort of precision community medicine, because they start with a household, they have a real grasp. And I feel like in Spain the GPs are more sort of, I started calling myself a family and community doctor. I don't know if that's legal, Chris. but you know, I just love to be a sort of like a family and community doctor, because when I went to Brazil in December, I saw how the GPs really own the neighborhood. They have a real understanding where people are, and I think this is not a million miles from how it used to be in this country was, and now it's kind of become this system of rotating strangers. So I think how can we and I think the community health workers for me are kind of like super highway to that. And how can you bring the health trainers or health visitors, which the community health and wellbeing workers in Brazil are based on, actually British health visitors, is this kind of like outreach to the family, understanding your neighborhood. So
Hi Victoria, thanks for a great talk. No, I was just going to say that I think we have to look at, the patient satisfaction surveys recently. The satisfaction has plummeted, absolutely plummeted. And it used to always be very high, 80s, 90s. It's gone down to like 30s. And we have to listen to the patients. That is absolutely, because we can't come up with all these ideas ourselves going, this is being very, old-fashioned, saying this is what's best for you. Why has the satisfaction dropped so much? We have to ask that clearly some things have gone quite wrong for the patients, and what has actually happened. And from just speaking to patients, I'm doing a bit of research at the moment. It's great. I speak to patients for about half an hour, have a proper chat. I say, how's your GP? How do you find it? They all just shake their head and say, and it is slightly, especially possibly the older generation, the obsession with technology. Not what a lot of them want to do, to be honest, is they just want to go to the reception, say, I'd like to see my doctor, and make an appointment. And if we ignore that, at our peril, probably. And also, I think we really have underestimated the power of face-to-face contact. And the people who the last few years have said, oh, we don't need to see any patients face to face. I'm afraid it's just total rubbish. I mean, it's unsafe rubbish. Saying that, and that many people don't feel that they've been dealt with properly unless they've actually been assessed in person. And I can understand that. Because if you're ill.
Yes, and with regards to health trainers and health visitors and the members of the multidisciplinary team, I guess the journey we went through the integrated care work is that understanding each other's strengths. And that's where multidisciplinary teams are useful, when they bring skills that as a GP I don't have. We don't want extra professionals to do my job. It would never be as good because they didn't have my training. We want other professionals that can add skills that we do not have, so that we can provide a truly holistic type of care to patients. So what the health trainers in this case with chronic pain, back pain, added was helping the patients to deal with this fear of moving. And we know how activity is actually something that can help back pain. So I had my patients a lot of them never did any exercise in their lives, and they were really scared of engaging with any activity. They thought it's going to be harmful for them. So the health trainer was excellent in trying to enable them to engage with physical activity, very, very basic one. And of course, being in an environment where other patients were with them in a group setting helps as well, because then you learn from each other, you develop connections, you overcome these difficulties, I think, a lot in a much better way. And with regards to what David said about GPs, and it's fascinating, isn't it? We've never before offered so many appointments. In terms of activity, we are providing over 1 million appointments every day. And yet patient experience has gone down. So surely we are doing something wrong. And I think it's exactly that, the lack of continuity, the fragmentation of care, the fact that the patient doesn't really know who they see anymore. It reflects the lack of satisfaction. So I did some research on access and with inclusion health groups, so the ones that are the most underserved kind of communities that we have, and on digital access. And some of them said they wouldn't mind actually to have a consultation over the phone, provided they knew who the person was. So I think telephone consultations can work within a context of continuity. If I know the patient really well, I've seen them before, they know me, and they trust me, I can give them a call for a follow-up to check how they are doing, and that will be fine. But I think doing all our interactions online or by phone, when you have never met a person before, I think it can be quite risky, and certainly not as cost effective.
I'm obviously, well, I'd like to say that when I was growing up, I'm quite old, we had a GP called Dr. King who wore a bow tie, and he knew all of our family, and you only went to Dr. King if you were really sick because you were terrified of him. Like, you know, there was nothing about. I miss Dr. King. But as somebody who's working with elderly people, I went to a PCN event in Chiswick this week to meet with the community, and everybody I spoke to said, "Oh yes, all our services are on our website." And I said to them, "Yeah, but I'm working with people that are still working out of the yellow pages. They aren't accessing anything on a website." And I discovered amazing services that are being provided, paramedics that are associated with the GPs that will come to people's homes, but nobody's got any idea that these services exist, let alone
adding my voice to the carers bit. My mum's just turned 100 and I look after her. She lives with me here. And it was really important to me that the name GP, I call him by his first name, comes here and we sign the do not resuscitate form together and agree. After that, it's fine to have telephone follow-up. If you don't have that initial trust, basically looking people in the eye, appreciating that the plan is a shared plan, then you don't. And, you know, I take a 100-year-old lady off to the practice and they don't realize it's actually quite difficult to get her there. You feel a bit irritated. And I go to a consultant cardiologist who says, insist on putting a defibrillating pacemaker in her. And so, well, actually, she rather wants to die, actually, and she wants to die of a sudden cardiac arrest. So please don't take away the things she's looking forward to. But the inability to grasp these things seems to be around with most GPs. Thankfully, I've got a GP who gets it.
It's really important that you started with sort of surveying what's happening now and to look to the future. And I think quite a lot that's come out from everybody that's been speaking, and not least yourself, obviously, is the importance of continuity of care and knowing who they are, who these people are that are looking after you. And you also very rightly said that to make an interdisciplinary team work, they do need to know what each one of them can do and respect that. And I think that's really important. So one of the strategies that's really vital is within each team is getting them to talk about their skills and what their scope of practice is, because until you find out about that, it can be quite revealing and very successful. But the most important thing, I suppose, was communication, isn't it? It's all down to communication. And the link between acute and community is one of the weaknesses in our system. So how do we build that link? Because once the patient leaves the hospital, it's often like going into the wilderness. Shouldn't be, but that's the way it is. So I'd really support what you're saying. But I think you're right. You've got to know where you're heading for. So what is the direction? What are we trying? When will we, what will it look like if it's better? And clearly one of the things is patient satisfaction, as David mentioned. And I presume with David, the patient satisfaction questionnaires do say why they're not happy, as well as that the fact they're not happy. Is there actually a section that indicates the reasons? Because we could use that. There's a lot of stuff out there, and I think Pip's indicated as well. There are people in the community. So each practice, each centre really needs to look at what's around it. Connie's talked about, linking up with the community workers and how successful that is. I think maybe GPs sometimes, because they worked so hard, may feel a little bit like they're in siege, and maybe they need to break the walls down and be encouraged to go out a bit more and connect more, to see themselves as part of the whole system and find out what other people are doing within the system locally, because it's not going to work the same way, say in town hamlets and maybe somewhere in Shropshire.
I think we are all aligned on the principles. It will be interesting to see what the health plan will say. I suspect it's going to be high level. I hope it will give us an opportunity to shape things going forward, depending on the needs of our populations, rather than being very prescriptive on what we need to do. If this is the case, I'm looking forward to your ideas and suggestions going forward.
That's a dangerous thing to ask for, but carry on. One thing that strikes me that I'll stick in while you're there, Victoria, is that when my wife was dying at home, she didn't have a day or night outside of the house in the last 10 months of her life, not in a care home, hospital, or hospice. And because of the illness she had, she could have been there all the time. So we saved the hospital enormous amounts of work. But it actually cost the NHS more because there was no way of transferring the funds we saved, the work we saved over there, to the extra work that was required in the community with the various people involved here. And that strikes me as a very difficult thing you have to take the hospitals on, I suppose, about actually letting go their money if we're going to be doing their work.
Yeah. Yeah, this shift of resources is going to be really, really important.
I can probably stay a little bit longer if people want to.
Okay.
Like 5 or 10 minutes.
So you are the kind of clinical lead for the Community Health and Wellbeing Workers from the Brazil model you modestly call it Westminster, but I think you're probably a little bit more than that with a UK reach. And you with Matt Harris and others from the London are pretty involved with trying to get this adopted. Indeed, I know the NAPC is very actively supporting the model. So for those of you who went to the last meeting or don't know, maybe you could give just a very short introduction to what the model is before we move into discussion about how do we stop it being hijacked by top-down forces that want to micromanage the world.
So what it is basically the Brazilian model started in the early 90s, and it was based on the fact that Brazil only had hospitals at the time and no primary care infrastructure. So there was a cholera epidemic, and the government then got local people from the community to look after about 150 households regularly to sort of help out, see how everybody was, and then the GPs came later. And then basically that's now the family health strategy or the primary care structure in Brazil. So you have a GP practice with a GP, a nurse, and 5 to 6 community health and wellbeing workers who look after about 150 households on the patch. And Matt Harris, who was a GP in Brazil in the early 90s, was really impressed by just how efficient they were. Even though they're lay people, they're not medical at all, but they really specialize in building relationships with their households, and they can really tell when somebody's off, when they're deteriorating, or there's something going on for the family. And because they look after about 150 households every month, they don't have a sort of ballooning caseload where they have to discharge people. From 1 month to the next, most of their households would be fine. And it's basically sort of health promotion, chronic disease support, social support, kind of being a trusted first contact in the community, but also being sort of plugged into, integrated in the GP system and in the community and local authorities. So they go into schools to teach children about oral health. They run community coffee mornings and events. They have public health events in the surgeries and engage patients there. So they're real sort of community infrastructure. And we thought in 2021, like, this would be great here because we don't have a role like this. It's just like one role for consistent relationship building. As long as you live in that building, you have a community health worker. And when you move out of that building, you lose that community health worker. So it's very much sort of bolted, it's place anchored in place. And so we did a pilot in 2021, and it was hugely successful, and we've now scaled. We couldn't have done it without the NAPC, so there are currently 25 sites that are at various stages of developing it, but just to say that it's entirely grassroots. And I think this is kind of the success of it, that we've created a community of practice with the National Association of Primary Care. Cornwall saw what we were doing in Westminster and came over and said, we want to do that in our patch. They now have 60 community health workers in Cornwall. So people come together. Our CHWWs, our community health workers, went over to Cornwall to talk to their CHWWs. They have a WhatsApp group to exchange resources, and it's just a giant sort of sharing fest. So whenever somebody comes up with something clever, they kind of share it with everybody else. So we've got an Octa app that we've developed where they sort of record the data. and that's kind of socialized around. We have a standard operating manual, and the NAPC is kind of really crucial at sort of fielding requests, guiding people, making sure that the principles are followed. So just to say that the 4 principles are the CHWWI principles. So it's comprehensive at the household level. Everybody within that household is in scope and gets seen. And anything that is of the concern of the household is of concern to the community health worker. So they're kind of agenda free in a way, which is really important. And I'll talk a bit about how we can safeguard that they don't become kind of task mules where they just do medical tasks, and hyper local, so people from the community where they live, serving that community. Universal, so they see every single one of their household once a month, but they spend proportionally more time where, say, like somebody is dying and they need to be there every day, or somebody had a baby, and integrated in the GP practice, so they have access to the medical notes. They wrap a team around the residents. They don't ever do everything themselves. They bring in the right people at the right time to help that resident.
Can I just ask you, Connie, you say that Cornwall, somewhere in Cornwall is developing the same model based on the work you've been doing in Westminster. They're very different communities. So how does that look now? How is it looking between these two different?
Yeah, so they've got 60 community health workers in 9 locations, and what you find is so when Matt Harris was talking about this model, people said like, oh, Brazilians are so different, you know, they're much more friendly than us, and they tolerate the intrusion, and actually what you find is that people are people, humans are humans, and actually what works in Cornwall works in Westminster, works in Brazil. You know, at the end of the day, people want respect, dignity, warmth, security, and human-to-human contact. And I think we were really surprised. I mean, the CHWWI's got a lot of rejection in the pilot. It took 11 door knocks to secure a visit, but it's not because people were rejecting it, but because this community in particular, it's a very deprived community, one of the most deprived in the country. They're so hurt by the system and so fed up. So, you know, whenever they open the door, they said, like, you're from the local authority, you can just bugger off right now. And if you're from the GP, that's even worse. And then they would say, like, you know, actually, we're kind of also from the community, and we're in this liminal space. and then, you know, people would go like, oh, okay, or, you know, sometimes it took 6 months, 1 year, even 2 years for somebody to really open their doors. But I'm surprised how receptive people are to it. And I think when you talk to people about it, the idea that somebody's kind of gonna come and sit in your lounge and ask you everything about your life sort of seems not very palatable. But actually when you kind of put a face to a name, they were invited to funerals, weddings. You know, people would ask them to, because they're from the community as well, so if somebody's dying and they know the whole family, they can sort of go there and sit with the family, and there's no it's a kind of like warm relationship. There's no rapport needed. It's already
well, I became a local authority councillor, of which some of them were my patients, and it was interesting that, just as a funny aside, when you used to knock on the door canvassing at election time, some patients used to panic, said, we haven't called the doctor. Anyway, that's a separate thing. But it actually changed what I've thought of my role, because for the first time in my life, I was asking them for something, which is their vote. And I found that quite a good wake up to think about my role as a community worker. I have to be a GP, but so I think that was important. Otherwise, it was just, I think, people just accepted it. I don't think I need to add any more, but it was the fact that it changed what I thought of me and the power differential that I thought was the most significant thing. I was a councillor for 11 years and thoroughly enjoyed it. All of them were my patients, but it was in the area where I worked, so I knew a lot of the area and so on. And I just found it fascinating. And it also gave me a huge insight into councils as well, because generally the medical world tends to look down on things like councils and all this stuff. So it opened my eyes, but it was that relationship locally. And one of the things we did was, of course, the ward councillors I included on like a community group that we had to feedback on what we were doing. So it was a nice, for want of a better word, integrating approach as well that happened.
I just wanted to say, in terms of how you prevent them from becoming sort of task mules that are transactional and biomedical, I think picking the right people is really important, because you recruit them on character, not characteristics. So, team players, good listeners, good communicators, very impassioned about the community, very empathic, culturally competent. So, if you pick those, you're fine, because they'll kind of sense that. So they're saying that themselves. We gave them the Brazilian forms to start off with in the pilot, and we said, can you sort of fill that in when you have your first visit? And after probably a month, they said, we're not doing those forms anymore because they get in the way of the relationship. And I think so when you say to them, so if you had people who were just caring about the tasks that the doctor sets, and they go, yes, the resident wanted to talk about being worried about their son doing drugs, but can I just get you to fill this in about dementia, and can I take your blood pressure, and can we do the cholesterol? And it's a bit like, any relationship. If I had a nice cup of tea with you, and then you think we're having a good time, and then I go, can you lend me £100? It kind of like, it kind of gets in the way. It kind of becomes a bit sort of like, oh, there was an agenda here. It's not really about me. And patients sense that immediately. And I think the community health workers have to safeguard that relationship, because they have to sort of have this relationship over a long period of time. So they push back quite naturally on that and say, I'll do the blood pressure if my resident wants that. And that's a good thing that I have in my arsenal, but I'm not going around measuring everybody's blood pressure and knocking on the door saying, can I just have your blood pressure? So I think that is a worry that you don't need to have. What I worry about is that the constraints. So when the government, when West Streeting was talking about go wrong, to Steve's point, yes, I think, I mean, I'm a living example. I've kind of, like the Web Estate. I live in Purley, and the Web Estate is kind of like on the other side of my and it's very, there's no community. It's just basically CCTV cameras and kind of big gates. So I don't know what that's all about, but in Brazil there's also a bit of a divide in that people who are better off will use, I mean, everything is kind of sort of shifting towards the US model, the biomedical model, more doctors, more hospitals, and I think the fact that we are now implementing this model in the UK, and the NHS was an inspiration for that. They're kind of like pausing a bit, going, what have we got that we need to protect? I practice as a GP. I've got a lot of very wealthy patients as well as very poor patients, and both are needy in different ways, and could do with a community health worker.
And my reading of the primary care research in this sort of mode of organisation, of outreach and so on, is that looking at primary care as a cooperative process, the inventors of it, the South Africans, lost it for political reasons. The next group to take it up were in Israel, and they also lost it for political reasons. The spread after that to the United States, and you can guess what happened there. Once the gentrification got going in any district, the need for a person-oriented approach decreases.
It strikes me that people are helped by having a focus to collaborate in order to collaborate. And if you don't have a need to collaborate, it's quite easy to stay watching the TV. So let's continue this theme about how do we keep the role to be politically and practically embedded in community development and not merely micromanaging people. David, Colin Tomey first, then Mummery.
Well, actually, I was responding to Steve really a bit. It depends what you mean by community, because sometimes we get a bit roseate about the local community being the houses locally. All of us have communities extended communities too, friends, neighbours, former neighbours. So, and that's true of poor areas. I worked in quite a socially deprived area. And so it isn't just the community that people relate to, they have other people as well. So I think we shouldn't get a bit too romantic about that localness too much. But there's no doubt about it. I mean, I live in a moderately middle-class area, and it's small. It's a small sort of villagette almost. And we work at it. You know, we have events and things, and so people are. And so when we have quite a lot of blackouts here because of the way we're semi-rural, people muck around and come around and say, is your generator working and things. So, but I think you have to work at these things. And middle-class people might be more anti this, but I think it's how you go about things, really. I think to make it it's a working class thing rather than middle class thing, I think is too stark. And also we've got to accept that people's communities are often not just local, they've got how much wider.
Yeah, thanks, Connie, for a great talk. And I'd like to echo actually on from what David said. I'm actually quite interested in trust, in the importance of trust and levels of trust. And actually, Catherine, I'll be interested in your comments, because did you watch the Simon Reeve programme about Scandinavia? It's like he did 3 parts. Basically, they're very high trust societies. They tend to trust each other. They tend to trust the government. They've got shops where you just go in and put the money in a pot and take the stuff. And for a successful sort of social cohesion and, you know, implementation of things like this, I do think I'd be interested in views, Connie. You know, trust is such an important thing in that, you know, we think we're going to be scammed the whole time at the moment, don't we? You know, every phone call we get, it's like, oh, is it a scammer or is it someone trying to defraud you? And it's like, I think unfortunately in the UK, trust has declined, I would say, on the whole. It's probably quite regional. Maybe I think in smaller communities, maybe more rural or close-knit communities, you do have still high levels of trust. But just generally, there's not great levels of trust. Yeah. Certainly not on Scandinavian levels. I don't know about other places, but
I wonder whether that's. I mean, so we definitely found that the trust was not there, and you know, all this vaccine hesitancy during COVID, where you know there were targeted outreach campaigns for people from global majority backgrounds, and why they're not taking that up, and actually sort of understanding that they've been so hurt by the system, and there's no, you know, why would you suddenly be interested in my well-being when I always come last, and you know, so that needs repairing. And I suspect that in Scandinavia, because there are more equal societies and more kind of, you maybe, I mean, Catherine, you can say better than me, but I think that you genuinely think that your government has your best interests at heart, which I don't think is true for the UK, and definitely in the last kind of decades. So is it also a political thing? For example, in Brazil, Bolsonaro did his absolute best to try and get rid of the family health strategy, and couldn't, because it was so rooted in community that people were very fond of it. A bit like the NHS has been battered and bruised and still here, kind of, you know. I wonder if it's more about sort of like the ideology of sort of individualism and you know, putting the person before the community, but it's not a natural way to be. I mean, there's only community was really important in the UK as well until a few decades ago.
I think that you can build trust and communities. They're a verb rather than a noun. Yeah. And I know some people who I can trust always to be thoroughly nasty and undermining and self-defeating and taking. So we've actually used the word trust in a particular kind of way of trust, which means that they're actually going to help us out. And I wonder if there's sort of trust plus and trust minus. And trust plus is helped by continuity of care, when you actually get to know a human being who actually does do what they say they're going to do.
Well, I was thinking about it as you were saying it, because, yeah, we are trusting community or a country. You can walk in any city and find someone having a yard sale and just putting up front or selling home knitted socks, and there'll just be a little bag you put money in, and then you take one and put the money in, and we don't really check it. I think, as David Mummery said and David Collin-Toman, it is about size and as well where you are, but the smaller the city, generally, the more the trust. So if you go to rural areas, we don't lock our bikes, we don't lock our front doors, maybe in the nighttime, or if you go on holiday. But if you go in Copenhagen, you need to lock everything and it might still be stolen. So it really depends on where you are. I mean, my parents used to have a little house on an island, and there you don't lock your cars. I mean, it's probably also because otherwise you can't get off the island, so where you're going to take it. But it is a trusting neighborhood, and it's I think maybe it's community. I can't really, culture almost, I want to call it. We're such a small country of 5 million people, 5.5. In the entire area. You know, if we meet someone out in the world and they're Danish, we assume that we are already friends, because it's so small. I will say, as time's gone on, like in the UK, we are lacking hands, and therefore we don't have the old school rural GP anymore as we used to have. But you don't have to go back many decades to find them. I was in a small one-person managed clinic in 2021, and he still had the doorbell where you would ring at 2 o'clock at night if your wife was in labor. And he said that, 2 decades ago, he would still be working round the clock. And then as centralization took over and the super hospitals were built, the doctors were collected, especially where there were few of them, in what we call health houses, which house different specialities, which were great for communication within the house. And, you can just go upstairs and ask a ear, nose, throat specialist. But sadly, it wasn't great for the communities. But I did get 6 months of trying how it felt like to be a community doctor, where my first patients actually booked a time to meet me, not because they had a problem, but because they saw someone come in with a lunchbox and they assumed that would be the new doctor in the house. And that was an experience that I haven't tried since.
I would just emphasize what you were saying collectively almost, as you were demonstrating trust of each other. I think trust in community is absolutely a key part of that, and that's part of the degenerative changes that are occurring in American culture in general. You've been making references to the American biomedical model, and I would point, as I often do, to dementia that was mentioned by one of you at least, as an illustration of these real challenges, because the pharmaceutical industry and the biomedical establishment is trying to make everything biological, biomarkers. Meanwhile, we're really struggling in the long-term care system with the need to provide care. And that long-term care system is focusing more on community in general. The amount of money being put into community services, which, I'm a believer in the community health worker, social worker kind of model that you've been discussing in general in these sessions. I think trust is based on believing that somebody else is both providing you accurate information as best they can judge, and in a relationship where you feel that they're at least willing to consider your interests in juxtaposed to theirs. The Trump enterprise is just absolutely distorting that, and hopefully we can recover from that. But it is an intensely political process, and I guess I'm going on and on and on. I've done a little work in Ohio with state politics, and I do agree that there's a commonly quoted aphorism that all politics is ultimately local. So I really celebrate those of you that have taken on that role as some kind of representative of a local area or region.
You're also pretty famous for intergenerational schools and developing them and maintaining them, sustaining them. I wonder if you could just add in a couple of words about trust in the context of using schools as a place to learn and build communities.
Well, we try to emphasize school-based healthcare first, because I think the general rule in life is the earlier you learn good habits, whether it's about health or about trust, the better. So absolutely, I think schools sometimes get neglected when adults talk about community, just like long-term care facilities get neglected. And actually, there is a certain intergenerational solidarity between kids and elders who tend to be forgotten in some of the development of services. A huge issue for me in an era of the climate crisis, which I'm ethically obligated to mention on every COIN call, because it's in the background and increasingly in the foreground as we all approach heat waves. And I think that's where young people are also losing trust in older generations who don't seem to be able to act to reverse some of the problems that they have created. And I think that's contributing to the enormous mental health issues that young people. If you're in a community where you can trust people, you're likely to have a better start at mental health than in a community where you don't believe the adults are really trying to help.
Peter, in the absence of seeing other hands here, I want to put it to you or to the group that we can make the homes where there are difficulties, let's say there's a carer, because carers often represent people who are particularly vulnerable or got multiple problems or whatever, as a learning space for life. And I was thinking about this last night because my niece visited my mum, of course, who lives with me, is 100. So ours was the first house she came to with her boyfriend to tell us they were going to get married. And I thought, as well as the fact that that was a lovely thing to do, it said something about families, communities, learning, appreciation, families that are created rather than given or something like that. And then the Ukrainians that came down, who lived with us as well, as just an 11-year-old, found she didn't quite have her usual translating job. So she started dishing up the food and put it on the plates on the table. And I thought this was so spontaneous and, well, lovely, really. And I thought inside this, surely there must be something about how you learn about life. I also added my son also took up the role as cocktail shaker maker. And all this happened just spontaneously in response to the moments. I'd love, Peter, anyone's response to that, but Peter, particularly your view about how that fits in with the idea of learning and these kind of things we're talking about.
Before, I sometimes say our school is somewhere between a small community and a large family. And I do believe that, when you say family values in the United States, it's awful. It's a term that's been co-opted by the right wing. But in general, I think that the cultural issues that we're dealing with have to find a deeper place in family. And I think one way to find that depth is exactly, hello, Jack, what you were saying about caregiving and people who are where the family is dealing with something like an elder who is struggling in one way or another. I think we've so undervalued caring in general. And I'll say one last thing because I think it's terribly destructive. The lay organizations that represent disease categories, Alzheimer's Association, Alzheimer's Society, have been bought off by the medical model. So I think we need different places where families can unite and talk about issues without being co-opted by the existing ways we think about health. Yeah, so I absolutely want to embrace what you've been saying, Paul, about this important intergenerational aspect, which almost shouldn't need a word. I mean, life is intergenerational, and we just need to bring some of the values and the mutual dependencies and the interdependencies and the long-term perspectives that brings into our communities.
I think the models are absolutely spot on. I think the problem I'm having is reconciling this with what may be coming out of the 10-year plan and potentially concerns about the direction the 10-year plan is taking, and thoughts on how this could be almost continually influenced, and almost how do you keep the development of community, and whether that's through the community health workers or other means, because in the past I've done other community development and making links into communities, whether that's through getting the links to voluntary groups and enhancing those links with general practice, etc. And I think it's so vital for neighbourhoods to work to be able to have those links. My fear is that the model that may come out may be a very digitally based model. We've heard things about the NHS app coming out already. Beyond that, it's the focus on access, taking demand from secondary care, waiting time. Sorry, I'm putting a real downer on the meeting, aren't I? But it's almost, you almost want the neighbourhoods to develop and show what's possible in spite of the policy direction. And that's a bit I'm trying to find difficult to reconcile. And I know I've had conversations with Paul about how do we share the word more widely around COIN principles. But it's, how do you help that to happen if the direction is almost not encouraging it? Sorry, that's a lot. That's a lot to say.
It's not dissimilar from the discussion about how to avoid the community health and wellbeing workers from being medicalised. Because if people think the only thing to do is to shout at people and control them, you haven't got the starting point of a mindset to be able to make these things work.
Well,
I couldn't agree with you more.
Absolutely. I mean, I think one of the things that we've been saying for quite a long time before the election, though it came much earlier than we expected, and obviously since, is how do we influence policy? Because once the plan is there, then everybody starts to march to that particular beat. And I think it's really important that we influence what's happening in the development of the plan. I worry a lot about the sorts of things you're saying, and indeed, the fact that in a way, how much consultation, I know there was the consultation, but I'm not sure how. I think that was done in one particular way, and I think maybe we wonder how much has actually been taken on board.
But I'm teaching health policy to multidisciplinary graduate students now, including engineers, social workers, and nurses. And what's been quite distressing in teaching about the healthcare system is that I usually teach people how to be influential, how to look for rules and policies that are being posted and debated, and reach out to policymakers to influence those. And what's happened with a bunch of the executive orders coming out of the current administration is that they've actually written into the executive orders, and there is no reason to comment. We don't need public comment on this. And so our public comment loop that's been expected in policy and in the US system is being dismantled aggressively right now. And one of the examples that I give when I talk about my limited experience with the UK system is the fact that the 10-year plan has been published, and they're asking for feedback. And so use it while you've got it. Make comments, participate, include policymakers. I was meeting with policymakers in Nepal in the last couple of weeks, and part of what I was also giving as examples are some of what I experienced again in the UK, where where the health secretary would show up at a King's Fund meeting and we would talk about healthcare and policy as it was being deployed and implemented. As imperfect as it is, as much as we may disagree with certain parties that happen to be in favor or not at the time, the participatory process is messy, but by all means keep doing it. The example I want to give from my own practice as a family practitioner, family nurse practitioner in the US in a relatively middle class community, when I had a worry about my patient, her blood tests were quite concerning, and I called her at home and didn't get an answer. I only had one option. I needed to call the police for a wellness check. And the police showed up and knocked on the door. She said she was fine, damn it, go away. I was still concerned. I reached out to her daughter who lived in another state and said, I'm really concerned about her. I got a call at the office saying, stop intruding in my life. I don't appreciate it. She died 2 days later. And so we don't have a health visiting system. Now, I have family members in hospice in multiple states, and I'm having a wonderful experience with a Medicare paid for hospice experience. And it is very communal. But when my mom's neighbor died, I learned about it when the wheelchair was being wheeled back out because hospice had delivered it the day before. He got assigned to hospice and then died 2 days later in the house. And in a community where everybody has to be over the age of 50, in my mom's community here in Arizona, they're not even sharing things like the free resources that are coming through hospice. And so suddenly the few neighbors who knew each other showed up to see, like, where'd you find a wheelchair? I've been looking for one of those. But yet he didn't get the community services he needed, like my mother's getting. And so, this idea that you have to call the police to check on the door and then they still don't trust the visit is what we're battling with. And I haven't started to talk about the fact that most of the caregivers in communities in the US are immigrants who are now wondering if they can safely drive to church or drive to work because they're being deported. And I'm hearing those stories on a daily basis as quite concerning. So trust matters, engaging in policy making matters, and having an infrastructure that's imperfect, but at least addresses the different roles like social workers play in our community to show up and provide coordination of services is something I've never known in the US. I've only known it through the UK. And so imperfect systems are better than no systems and are certainly better than those that are being dismantled.
David, are you going to cheer us up?
Yes. No. Maybe. I've spent too long in the civil service, maybe. So yes and no. It's too late to influence much of policy for the 10-year plan because it's virtually done. Though from the little bits I can pick up, some of it has been influenced. So there's a bit of a positive gain. Politicians, in more of my experience, want success stories coming back from service. There's nothing to stop many of us, which is what I was talking about even yesterday, to start doing some of this primary care development, which is hence my question or talk to Victoria. We can start developing some models in primary care, and like the primary care home, which we influence government policy, there is an opportunity. But we get quite passive. So, that's the policy. Well, there's nothing you can do about it. You hijack the damn thing. Don't fight it. Hijack it. Use it. And I've got, a reasonable amount of experience in my, I know, albeit very long life, that it works. Because if you can develop better models for patients and communities or whatever you've got, politicians quite like it. They want good news. They don't like us whinging all the time. And so there is an opportunity. And so what we can influence is policy development rather than the policies nearly set now. And there's nearly always some opportunity to do that.
with Laura's saying, because I guess I have trust in no matter what politician I have in my country, I mean, some more than others, to not only have a similar set of values. I mean, we have less disparity a lot between our extremes on both sides than you have in America, but I also have trust that they have the same end goal for me, which is quality healthcare and education free for all Danes, regardless of who you are, who you love, or where you come from. And I don't see the unity in the goal in America anymore. I don't see that they're working towards the same end goal. And I think that's where I would get personally very distrusting. For the UK, I still feel like there's a similar goal. I think the disparity is getting bigger and bigger and bigger, and I do agree with David Colletone that we do need to get a move on while we can.
There is a bit of difference, isn't there, in as you said, Kat, in size, but also in public debt and stuff like that. So the Scandinavian countries, I think Norway has no public debt at all, you know, and if you compare that with America or the UK, you know, it's a very different story. So, you know, the funding is a different sort of side, I think.
Yeah, sorry, they do have, you're correct, Chris, they don't have any debt in Norway, but they are actually spending less on their healthcare than we do in Denmark.
But I think there's a huge amount to play for, and we're going to do that. So on the July the 29th, we're going to hold them. Laura is going to be in London. David Colletone will be down in London. We'll be, hopefully all you will be down in London. And afterwards, we're going to go either to the pub or probably to my home, where we'll have lots of chance to have informal discussions afterwards.